All right, welcome, friends, colleagues, students, citizens of the world. It's your boy Leroy Horton, back with another amazing episode, an exciting episode of the Teach Me Implants podcast. With me today, I've got one of the most special people, one of the gems of the Northwest, Dr. Estell Williams, who not only has she been a rock star here in the Northwest, but given that she did her medical training here at University of Washington and her residency, if I believe, but she's got a big list of degrees from everywhere else, from Xavier to UC Davis to University of San Francisco. I can't do your story justice. Briefly, tell us what was your path to get to where you're at today.
Well, thank you so much for the introduction. I love to share this opportunity with you and with your audience. So I just want to extend a huge thanks to
Oh,
you. My story is one of resistance and perseverance. I am the youngest of seven, the first in my family to go to college. I started at historically black college university at Xavier, where I was displaced after Hurricane Katrina, graduated from the University of San Francisco, and then did a post-bac year at the UC Davis campus and was able to continue on into pursuing medicine and my dream of becoming a doctor here at the University of Washington in Seattle, who welcomed me with open arms and continued to welcome me and foster my growth and development, where I stayed on to complete my general surgery residency and have now been on faculty, and just found out a couple weeks ago that I've now been promoted from assistant professor to associate professor.
oh my gosh, congratulations. And for those that are not in the academic world, they may not understand the gravity of that. And to have someone like you in a position like that who has not only been able to demonstrate your greatness, your skill, your knowledge, but to have that recognized and, as you said, embraced by the institution, I think is also just testament to what you bring to the table. So I'm so proud of you. So congratulations on that. That being said, as everyone who may have been watching the last few episodes know, we're going to get into the nitty gritty of some studies and some key opinions, right? And that's what, right now, you're on this platform as a key opinion leader because you are an expert. So we want Dr. Estell Williams, the surgeon, to give us her personal synopsis and opinions on some of these issues. So without further ado, I'm going to screen share and I'm going to bring up a concept that I know is near and dear to your heart because we've been in similar spaces doing some of this work. Okay, so looking at this screen, you could probably already guess where this is going, right? We had a number of publications through the decades, but this one here was kind of astounding and caught a lot of traction a few years ago in 2019 when it came out. A publication by Dan Lai looking at the percentage of black doctors through the years. And, the overall statistics show that the proportion of physicians who are black has increased by only 4 percentage points over the course of 120 years. And in fact, has remained almost unchanged since 1940, it's a daunting number when you look at the time span and the perception of how much progress we should have made in this particular arena. Which brings me back to this amazing study out of your hometown. This is out of Oakland with Marcella Aslan, who paired black men with either black doctors or non-black doctors. And what they found was black doctors, just by virtue of that cultural connection, were able to increase the uptake of diabetes and cholesterol screenings for the patients. They were 56% more likely to get flu vaccines. They were more likely to share information. And when you work out some of these statistics and project them out, it was projected that if you could ensure that more black men saw their counterparts as far as the provider they're seeing, you could potentially reduce cardiovascular related deaths by about 19%. So, because you have been in the world of outreach, of professional exposure to students. Now, for you, that's obviously something very personal. Tell us the what and the why for the things that you do in this arena.
Yeah, those are very two important questions. So I'll start with the why, and then we can delve a little bit into the what. So the why is exactly what you're describing, but it even goes further back than that. So this is an amazing study that you brought up, but I think that it's always important to understand where these numbers are historically rooted. And when you actually go back to the founding of medical education as we know it in this country with the Flexner Report, Abraham Flexner, that was charged by the Carnegie Foundation to help revolutionize medical education, because at the time when he was tasked with this job of helping to reevaluate medical education in 1913, there were a number of private medical schools. There was no regulation, privatized. And so they were trying to standardize the way in which healthcare was delivered. You know, a great intention, a great idea, but we have to recognize that at the time, where were we at as a country with the way in which we engage with certain racial ethnic groups? And so when Flexner was charged with this, there were, at the time of his report, about 27 schools that focused on training Black Americans into becoming physicians. When his report was submitted, after it was submitted and they revolutionized or, upgraded medical education, there only remained two, Howard and Meharry. From that point on, up until 1960, 95% of physicians that were trained in the United States were white. When you look at his report, he, and I quote, states that Blacks should be trained to be sanitarians solely for the purpose of preventing the spread of disease within whites. And so when we talk about the intentional creation of the way in which we see the world, these numbers, the data that we hear about, that wasn't by accident. We were intentionally written out of these professions. And so it's very important when we think about the work, what we are doing, to understand why we are doing it in the first place. And, that is the ethos from which I engage with all of this, is not that, we are somehow not capable, not able, not intelligent. It was intentionally crafted because we were never meant to be in these spaces, because they were completely crafted for only certain individuals to enter into the first place. And so that's where I always enter into these spaces when I'm talking to students, to let them know, even when you hear data about, individuals, especially people of color, performing worse on standardized tests, again, you have to go back to understanding how and why these were intentionally created to keep us out of spaces, not necessarily to test someone's intelligence or not. We are just as intelligent. We don't have different brains. We are capable. And the second step you mentioned is actually the most important part. We provide better care.
Yes.
And so it's important to keep that in mind as we talk to the next generation, because I think so much propaganda has unfortunately reached our communities to where people truly believe that we are not meant to be in these spaces, and we truly are. And so we do programs that engage students, particularly those starting at the early education level, because when you also look at data, the number of private prisons are built based on the reading level of students in that area.
Yes.
So when students are not reading at a third grade reading level, that's when private prisons say that we need to build a prison in that community, because it is a direct correlation between education and the private pipeline.
Right. Right. So this goes way beyond just, obviously we've demonstrated, and you eloquently spoke on the notion that we're able to produce better patient outcomes, right? So when we talk
Correct.
about representation, it's not just to brag about a set of numbers. It's literally for patient outcomes. But you're also making the very distinct expression and argument that it goes way beyond even just the patient outcomes, right? Because as a provider, you are engaging students at a younger age, whether they end up becoming doctors or not.
Exactly.
The fact that literacy levels can go up, that general education, confidence, self-knowledge, right?
Self-efficacy, the
Yes.
belief that you can accomplish something.
Yes, and then I think that's amazing. To go back to the presentation here, so to expand on that, however, I'm always a big proponent of, approaching a situation from as various sides as possible, as comprehensively as possible. And one of the things during the COVID era that I realized, and I was doing some work with the African American Health Board on messaging around vaccines. And this segment here is not about, whether you support or don't support vaccines, but we talked a lot around that time about the distrust of institutions, medical institutions, especially from the black population. And I always kept hearing this notion that, well, it's because of things like the Tuskegee experiment. But when I talked to most of my friends, my black friends, they didn't really know the details of the Tuskegee experiment that well. And as I started exploring very distinct messaging, and this is part of my messaging notes that I had back then as we were going out into the community and trying to recruit people for vaccines, was the involvement of HBCUs in the vaccine process, in the messaging process, in the fact that there was a fair amount of black doctors and researchers coming up with the vaccine between the various companies. And I'll exit from this here. My question to you is, we have to, at the same time, right, if you on your end are helping produce more black providers and you're creating spaces and opportunity for that care to be there, as a population, we need to change our perception and our culture and our value system to be able to come to those spaces that someone like you is creating. And the more I thought about it, the more I realized it's not just things like the Tuskegee experiment or any adverse experiences they've had just in medicine.
Mhm.
People are having adverse experiences of discrimination across the entire spectrum of
Exactly.
their life, from the schools, the grocery stores, the justice system, when they're applying for jobs. So it's this cumulative effect
Mm-hmm.
that has made us hyper responsive to even the slightest inclination of potential shenanigans going
Fun.
on, right?
Fun.
So, what do you say? How would you craft a messaging strategy to our people to say, hey, we are behind the scenes, behind the doors, doing our best to make sure that when you have the space and opportunity to receive care, it's the best possible care. But we need you to have some trust. What does that messaging look like to you?
I think that is one of the biggest ways in which we can actually help combat healthcare inequities and health disparities. And I want to actually push back a little bit on the framing around messaging and really shift it to think about how can we be more intentional within our communities. Because I think what we oftentimes, and we as even providers of color, we've become so indoctrinated into the way in which we have been taught to practice medicine and engage within communities that speaks to majority communities in the way in which they have complete trust in the healthcare system, but does not speak to the experiences of those communities that have not had trust because of very clear outcomes that is exactly as you have articulated. Not anything from the past, but their current everyday experiences with not being listened to, not
Yes.
being heard, not being validated, not being apologize to when they do have experiences in healthcare settings that are inappropriate, and that if it were a person who was of a majority group would not have experienced their healthcare that way.
Facts.
And so really what we have to do first of all is to listen to people, not just mimic or repeat like when we're taught in our healthcare systems, like, repeat back what you heard from them to summarize what they said to ensure that you're hearing what they're saying. No, actually just sit back and listen to what's being said. And when you can do that and they truly feel heard to, not explained away, not gaslit, not saying like, oh, I'm sure that's never happened. Like we really have to validate what people's experiences have been and then engage with them. I think a lot of times people feel talked at, talked over, talked to, but not listened to. And so before we even get to any messaging, it almost feels inauthentic when you go to message to a community when you're like, we've been screaming at you that this has been a problem forever and you never listen to anything we said, but now you want to come to me with this campaign talking about how you're on my side.
Right.
Why aren't we doing more community listening events? Why aren't we just having opportunities to come to them before there's a problem to try and repair the relationships in the first place so that when chaos does strike, when the next pandemic does come, which is going to happen, you already have that relationship built. But we just sit back and wait till something happens, and then we expect people to just jump because we say it. And we don't take the opportunity to intentionally build with our communities. And that's what I oftentimes do with the programming to engage with that next generation of doctors, is that to say, we're not expecting you to come to the White Ivory Tower. I don't hold my programs only at the University of Washington. What do? I take our resources and I go out and hold programming in the communities where they come from. Find the community center, find the high school gymnasium, and go out to those. And why do we know those community outreach events works? Because it is taking opportunities and resources to them.
Right.
It is being intentional about how you engage with them in the places and spaces that they exist every day and not being afraid to engage in those communities. And that's how you build and repair trust, so that when the messaging does need to come out, guess what? People are going to be like, oh, okay, this isn't the first time I'm seeing them. This isn't the first time I'm feeling that outreach. Oh, they listened to us before. We already have established connections and relationships.
Right, right. Now, that's interesting you say that because I can't say that I disagree with any of that. I agree 100% with that. One of the struggles I've had is, and let me show you a graphic here. We talk about the oral systemic connection, right? So, although I agree with everything that you say, one of the struggles that I've had is this notion of prevention, whether we're talking about individual health prevention or we're talking about public health prevention, community prevention. In this graphic for anyone that is listening, it really just shows from my perspective as an oral health specialist, as a periodontist, is the systemic link with the oral health and the oral cavity. And we know that gum disease has been associated with Alzheimer's, respiratory disease, obesity, diabetes, sexual reproductive health, and much more. It's not easy to get someone to change their lifestyle. It's not easy to get someone to come on board with something that they're not immediately affected by. In the same vein that you've probably seen as a surgeon, we have people with uncontrolled diabetes, very prevalent. We know they've been educated because some of them we've educated them ourselves, right? And for elective surgeries like I would do in my office, I need that A1C to at least be under an 8. You might be doing more emergent surgeries where that's not as huge a factor per se. But when it comes to even at the community level, how do you get people to buy in to the investment of prevention when they might be largely concerned about whatever it is affects them or their value system today?
That is oftentimes something I struggle with as well. And I think that, it really does go back to what you were highlighting even in the first study. When you have that concordance, when you have that cultural connection, does it happen overnight? No, right? But it does allow a bridge to be built that allows for patients to be more invested than they would have been if there wasn't at least some of that connection that happens. And again, we've seen the data pour out that we are able to improve those chronic illnesses when we do have intentional engagement by providers, especially race concordant providers in those communities. I think it's also hard when we have a lot of these social determinants that are converging at the same time that we're having these cultural nuances that are impacting the way in which we can deliver care. So you have individuals who are under or uneducated, who even with the best information that you can provide, when you're trying to create an understanding of how all of these health issues are combining to impact their overall picture, their whole body, their whole system, it's hard to make those connections. And I think we underappreciate how far we are from making those neural connections for them to truly understand the impact until it directly impacts them, right? Until they actually suffer a consequence. And then all of a sudden it's like, oh, I get it now. And that's unfortunate because we're like, well, I tried to explain. And I think that's where when we think about how more of our education has to be provided at a third grade reading level or less for so many folks, right? Like this is where you have to really understand like what we talk about when we say these social determinants about how educational level is going to have a direct impact on someone's health and how those are directly tied together. Because as we see the US continually talking about how we're underperforming in education, and yet we see the direct correlation with less investment in our educational system, you have to wonder, is that intentional to keep an uneducated populace, right?
You
And
mean
so
we're not the best country in the world? We're not number one at everything? Are you charging us with not being the best?
And then we also think about like, what does it mean to have, access to care is always this big buzzword and people talk about access to care. But when we think about access to care, it's not even always about proximity of a clinic to your house. It's thinking about like, even though there was a clinic at the corner of my house in the hood in Oakland, California, I still did not see a dentist until I was 14 years old. And it was when my dad got a job through the union that actually had dental benefits. He'd had some little sparse union jobs before, but he still didn't have dental benefits.
Yeah.
And so, when we think about people, they have a good job, they should be able to. That doesn't mean that job comes with dental benefits. And even when we say, well, they have access to care, they can see a provider, is that provider actually engaging in, meaningful conversations with their patients? Or are they a part of this hamster wheel where they have to get through 20, 25 patients in a day, and education they thought they provided actually didn't go far enough, or actually they weren't able to pick up on the nuances of this patient saying, oh yes, I understand, but they really didn't understand nothing that was going on. They were just recognizing that this doc had 5 minutes with them, and they were like, oh, I see they're in a rush, I'm just going to say what I can so they can move on their day, and I'm gonna move on with mine.
Right.
And so there's all these other external factors that impact it. And so it's hard for us to find like this one size fits all solution, because we're getting hit from all these different places at the same time.
Yes.
And so it being real, we recognize like this whole system needs to be blown up and restart over, right? Like nothing in our system is actually functioning to make us healthier. All we're doing is putting patchwork over a dam that's about to explode.
No, it's true. And I was just having a conversation with one of my colleagues regarding healthy foods, right? And how the problem is so nuanced, because most places do actually have healthy foods. And I did this kind of anecdotal self-study. You go to your Safeway, your Fred Meyer, a pack of flash frozen vegetables, 49 cents, under $1, right? You get a big bag of rice, $1 to $2. You get a rotisserie chicken, $5, right? You could literally feed a family of 4 for under $10. But to get to that healthy food, you're walking past aisle and aisle of junk food that's right at eye level with scientifically chosen colors.
Exactly.
But how can you educate a population, as you said, where education is lacking? And not to say that as a form of judgment, it's just the reality that we have. Because it's very frustrating when you do put these problems out, and what the institutions tell you is like, oh, but you got healthy foods. You're just not choosing it. You've got access. You're not valuing it. What do you say to the institution who oversimplifies the problem and the solutions while you're living this very nuanced existence within the social structure?
That's where you have to make for sure that is where the cultural mediation comes into play, right? And I think that I think I felt more, if anything, disengaged with institutions actually having the wherewithal, the knowledge, the commitment to change any of these. I feel like most of these are coming from a grassroots level. We just failed to make the investment to actually see meaningful change, right? Like they're spending a lot of time and energy trying to just find the next grant to put on their next event versus being able to do that higher impact work that's going to make long-term solutions. Or they don't have access to the researchers to help measure the outcomes that they're actually having in these communities that are seen on a small scale, but not a larger scale, right? And you have to highlight work like Dr. Margaret Tawawi, who's also in our Pacific Northwest community, who got burnt out by these institutions that she worked at, trying to deliver preventative healthcare and do that work for our communities, and moved to a private practice model, establishing the first private practice clinic owned by a Black physician in the Pacific Northwest that we actually have right now, and has wrote 2 children's books around plant-based diets, and goes into schools to teach our students about plant-based and healthy diets, right? And the thing about that is that, one, it recognizes the value that having those conversations at a younger level helps them to establish those habits earlier. And I think that's one of the things that we also forget is that, as you've stated, habits are hard to break. And if you've been doing that since you've been 10, 15, by the time you get 40 or 50, and you've lived fine, right? You've lived fine. Right. It's going to be hard to think that you need to do something different. But if you've established those habits much younger, then it's not going to be that big of a jump for you to engage in that. So think about just even engaging at her solution of writing a children's book and engaging with the young learners so that they understand what plant-based diets are and how to incorporate healthy foods in your diet early, gives them, from a Black provider who recognizes and understands the cultural importance and nuance of engaging with that community, how that's going to change that person's demographic over time. Now, again, it takes a long time to see that happen, but we also had decades of where people weren't engaging in that intentional education for our communities. And so you had a generation of folks who weren't spoken to about what it meant to actually have healthy foods and diets in there. And so I think that this is, again, the more we rely more on our communities, ourselves, those individuals who have the right intentional approach on how to help change the narrative. But again, it also goes back to why I don't believe in our institutions actually doing that, because we have data that proves the effectiveness of those types of programs. Right. But what we don't have is people making those intentional commitments with money, with funds, with partnerships and collaborations, right? Like, she's doing it on her own. I work at UW. I love UW, but you don't see them reaching out to partner with her to elevate that platform, to right. bring that to more communities. Why? Right. If the institutions really cared, wouldn't they be making those sorts of investments in those folks?
Well, it's that old adage, if you show me your budget, I'll show you your values, right?
Exactly.
Let me put up the last graphics. I know we're running low on time, and Dr. Williams got places to go. So let's see here. So I love where this conversation has actually evolved. And so the last graphic that I'm going to have here. So I want to talk about checklists, but I want to bring it back to the topic that we were just engaging. Now, for anyone that is listening and can't see, there's a study here by Marimaldi that talks about adverse events in the dental setting, with 14% of these being aspiration and ingestion, alarmingly 13% of them being wrong site, wrong procedure, wrong patient errors, which is damagingly scary to think about. And then when we look at the medical world, we know, and I kind of brought this up because in my experience, in my residency shadowing the anesthesiologist at Kaiser, I saw a tremendous effort put towards checklists before surgery, after surgery, and so forth. So in this Storison study, looking at checklists and their associated odds ratio for reducing complication. So you're going to be 30% less likely to have complications. You're going to be 60% less likely to have reoperations, and almost 70% less likely to have readmission post-surgery. If we look at this New England Journal of Medicine article, by instituting checklists, the death rate was cut by 50%, which we know if we were to take the notion of a checklist and its positive outcomes, or at least the reduction of adverse outcomes. Staying on this same topic, what can we do as individuals, whether we're providers or we're patients, to have a checklist for life to reduce our adverse events and or increase our positive outcomes as individuals, as citizens, as providers?
You are right up my alley, because this is exactly what we do within my field of surgery, is that, we have our timeout when we are starting in the operating room to make sure we identify, the patient, the procedure. We have the protocols to have anybody speak up if they recognize that something's not going on. And then, of course, we have our timeout to just confirm everything. And I think the way in which I always think about what a checklist does is if it allows us to create organization and structure. And I think the theme that I have kind of brought up again, over and over again, because it's a theme for which I operate my entire life on, is intentionality. Yes. It is creating an intentional, you are critically thinking about what is occurring and what solution we are hoping to have for this problem. And so when I think about like our ICU checklist, when I'm taking care of patients in the ICU, you go by you organize it by system or by problem, healthcare problem, and what is the intentional solution to address each one.
Yes.
And we can do that with our life. It's just like when you're going and you're trying to cook dinner. What you do, you want to make your list for what you need from the grocery store, so you have all your ingredients to make sure that dinner come out right.
Yes, and it better come out right too.
And it better come
we'll
out
let
right.
You know, because we will let you know.
And so, that to me is a checklist. It is like, what are the steps that you need to do to accomplish the goal that you're trying to achieve? And so, something similar has been proposed, even with trying to address healthcare inequities and health disparities, is doing an inequities checklist. And we've kind of talked about this within the surgical space, and it's lost momentum, but it's something that even my husband, who's a critical race theory scholar, Dr. Edwin Lindo, and we talked about this idea for every patient that comes into the hospital, having an equity checklist. where you go through and you think about what are the social determinants of health? What are the things that are going to impact their health outside of the hospital when they leave from here? And have we addressed those? Do they have stable housing? Access to clean water? Do they have transportation to get back to their doctor's appointments for follow-up? What is their educational level? And do they have the health literacy to engage in the follow-up and the instructions we're giving them to prevent their coming back again? Right? That's intentionality. That's thinking about not what just happens in these four walls, because there's only so much you can control in a hospital setting before they got to go back out in the real world and deal with all of the other, those things coming at you all the time.
Yes.
And what kind of ways can we be intentional and think about all of those things before we send people out in the world and then expect them to just figure it out?
Yes.
And I think that's essentially what we should be aspiring to at all times, is really being more intentional about what are all of the things that are coming at people and how can we more thoroughly engage in those instead of just they grown, they'll figure it out, or not my problem. And the thing is, it is, because when they come back to the hospital, what are we doing? We're saying, why are you back here again?
Right. Listen, I know you're pressed for time, so I will wrap this up. Brilliantly said. I could not have articulated it better myself, even if I had scripted it. I am anxiously waiting for your run for governor or president or something, because you absolutely will have my vote. But thank you so much, and I hope I can steal you away periodically, maybe every couple months, for a nice session like this. Everyone has just been enriched in the last 35 minutes, and I have done my best to bring the best guests on my platform, and I have not disappointed today. So thank you so much, Dr. Estell Williams. To all the listeners or the viewers on YouTube, you know my parting message: keep listening, keep reading, keep learning, and we'll talk to you soon.